in the name of God. Hello to all my dear friends and companions. I hope you're all doing well. Today, I'm going to talk to you about how to perform implant surgery in the aesthetic zone and in the anterior regions. Naturally, the first step, the initial stage in fresh socket implant surgery in the anterior and aesthetic regions, is the atraumatic extraction of the teeth. Atraumatic tooth extraction follows certain principles, which, of course, are beyond the scope of this article. However, in any case, we perform the extraction in such a way that the maximum amount of periodontium around each tooth is preserved. And in fact, it is this periodontium that will later help us with implant placement and will ensure the long-term survival and health of our implant. Now, if you agree, let's take a look at the upper right first socket, which we will subject to fresh socket implantation. As I mentioned in the theoretical principles, the drilling technique must be such that it is always right up against the palatal side. In situations like this, we really need to use drills that are either Lindemann or end-end side cutting types, so that we can perform our drilling right up against the palatal wall, very close to the palatal wall, and stay well away from the buccal wall. Here, you can see two starter drills that are available in different kits and brands, and have been included in their implant kits by different systems. On the right side, you see a drill called a lance. This drill is what we call end cutting, meaning it only has a cutting edge at the tip. When is it suitable to use? When you want to determine the initial position and location of your implant to pass through the cortical bone and enter the spongy bone, so only its tip is cutting. Meanwhile, on the left side, you see a drill that, in addition to having a cutting tip, also has cutting edges along its sides. This type of drill is labeled as such in commercial kits. It's referred to as a Lindemann drill, and in more scientific terms, this drill is both end cutting and side cutting. In the fresh socket of the aesthetic zone, as I mentioned, drilling should be right up against the palatal wall. And actually, here we're not creating a single point, but rather making a line along the palatal wall. The preferred drill for starting drilling in fresh socket implant placement in the anterior region is the Lindemann drill. So even if my kit doesn't include a Lindemann drill, I always get a separate Lindemann drill and add it to all my kits. That way, for fresh socket implant placement in the anterior region, I can start my drilling with the right drill. When you start drilling, you need to make sure that your drill is operating in the correct three-dimensional position, so your osteotomy is in the right 3D location. In this particular angle that you're seeing right now, I actually want to emphasize the mesiodistal angle because when you are standing directly behind the patient, it's really quite easy to make a mistake. If you're standing behind the patient and drilling in the anterior maxilla area, you might feel like the drilling is in a correct mesiodistal angle. But when you come and stand in front of the patient, you realize that's not the case. Right now, my handpiece is a bit distal. That's a mistake. The opposite can also happen, meaning my hand could be too mesial. Both are mistakes. We need to do our drilling in line with the direction of functional forces. Our cavity should be in that direction, and then our implant should also be aligned that way. So, a really good practice is to always check the patient from the front after the initial drilling. In addition to looking from behind the head, we should also look at our patient from the front. Let's see if our drilling is in the correct position. In fact, I ask my patient, ma'am, sir, please open your eyes. The mid-sagittal line is determined based on the line between the patient's eyes and the mid-pupillary line. When their eyes are open, The line between their eyes is imagined in my mind, and then the mid-sagittal line is the one that runs perpendicular to that line and passes through its center. If your drill is parallel to the mid-sagittal line, it means you're drilling exactly straight and directly. That was regarding the mesiodistal aspect. Now let's look at it from the occlusal view. If you pay attention, you'll see that my Lindemann drill is right up against the palatal wall. It doesn't touch the buccal wall at all. In fact, when I finish drilling and remove my drill, you'll see a line on the palatal wall, whereas you won't see any signs of drilling on the buccal wall. This is the correct way to drill. So, in terms of buccolingual orientation, I stay close to the palatal or lingual side, so that my drilling, the cavity, and the final implant are all close to the palatal side, with the expectation that the bone resorption pattern is toward the buccal. I avoid the side where bone loss is happening. I move away from the buccal side. I stay close to the palatal side. I've talked to you about the angle, direction, and orientation of the drilling. I inquired about the optimal mesiodistal and buccolingual positioning. Now, a very important point is this, and the question that comes up is, where should the entry point of the drill into the bone be? We've understood its angle. We've understood its direction. It should be close to the palatal, but where exactly should it enter the bone? Here, a really good reference point is the tip of your drill. You should go and touch the apex, and after touching the apex, move about 4 millimeters up along the palatal wall. That becomes the starting point for the drill's entry into the bone. On the palatal wall, 4 millimeters above the apex of the extracted tooth. So, this becomes the entry point for the drill into the bone. We're about to start drilling. This is our starter drill. As I mentioned, the Lindemann drill is ideal for this purpose. The Implant Motors drilling program has been set. The speed is somewhere around 1000 to 1200. Torque is 30 newton centimeters. The rotation direction is forward, and definitely with irrigation. Me. Now, my initial drilling procedure is successfully finished. Let's carefully observe the precise drill entry point located on the palatal bone wall. It is important to note that I meticulously ensured the socket apex did not dictate or influence the exact location where my drill was intended to enter the bone structure. I created a new apex. My new apex is on the palatal side compared to the previous apex. So now, inside this socket cavity, you see two apices. The apex that's on the buccal side, that's the apex of the extracted tooth socket. That dark spot on the palatal side, that's the new apex I created. It's on the palatal wall and about 4 millimeters away from the previous apex. My entire focus during drilling is to make sure the cavity I'm preparing is on this new apex, so that ultimately my implant will be placed on this new apex. I shouldn't let the previous socket dictate where I drill. Dictate to me where my implant should be placed. In fact, I need to completely reverse the equation. I have to stick to the palatal side and create a new cavity.